name is Dr. Ellen Rudy, and I oversee health and impact here at PAPA. And what we're going to do now is actually kind of take a step back and look at companion care, both from a clinician's perspective and then from a population health perspective. I mean, my background's epidemiology, so I do love data. And so with me to sort of share in this is Dr. Carla Perissinotto. So she is a practicing geriatrician, and she's also a renowned researcher at University of California, San Francisco, where her subject is loneliness and social isolation. So Carla, why don't you first just give background more about yourself and why, like what got you interested in social isolation?
So I'll tell you, I'm realizing that I decided to wear the same shirt and jacket. I changed my earrings just to, you know, trip you up a little bit, but that is me. So I'm a geriatrician and palliative medicine physician, as Ellen said, and I came to this because in my training, when I was working in the hospital, I would see older adults who did really well and some who didn't do so well, and it didn't always make sense purely from a medical lens. Maybe they had the same diagnoses, but some just got more functional impairment and some did really well. And I thought there has to be something else that is going on in people's lives that we're not measuring and that we are not trained to look at medically. And that's really what started me on this path. I'm also an anthropologist by training. I'm also a first-generation American. Spanish is my first language, and so I grew up in a community where diversity and being different was central, and that sometimes can leave you feeling different, feeling lonely, feeling isolated. So there's a whole bunch of different experiences that led me down this path, and ultimately, you know, essentially this has become my career of understanding the health effects of loneliness and isolation, particularly in older adults. I like to say I'm ageist, but more because I like older adults and don't like young people. So quite the opposite. But that's really what this is about.
Well, you know, I want to make a comment because you wrote an op-ed last year, I think in JAMA, right? That was talking about the true cause of death, and that for many older adults, the true cause is actually loneliness, yet that is not what you see on a death certificate. I don't think you could put it in it, you know, on a death certificate. So, you know, teeing that up, like that's where I want you to share both from your personal experience as a geriatrician, as a researcher, you know, how does loneliness and social isolation actually exacerbate health risks, and how are they the drivers of whole health?
Yeah, and I have to say, I wasn't prepared to hear the pals and what they said earlier, so it's really neat when you actually hear real life experiences, and I'm like, hey, I have that in data. Hey, Ellen has that in data. And then we hear the stories and they match, and that tells us that we're on the right path, and that's really exciting. Or also to have, you know, the leader of a health, I forgot I can't say health insurance, now I can't say that, in Oregon, leading health in Oregon, really talking about that this is where our priorities should be, like we're seeing it in real life, and that's exciting to me. So what we'll start with, again, is my view as a clinician. So it's really important to me as a researcher, as an academician, as a leader to really think about what I see in practice is what I want to study, and ultimately because I want to think about how we can improve the lives of older adults, improve longevity, and improve longevity with compression and morbidity so people are leading healthy lives. And I'll start with this story, and this is not my patient, but I think it exemplifies what we may be missing and what Frank may have said that may have happened to him did he not have a community. So this is a story of Marvin, who in Michigan was found frozen to death in his house. And he was found frozen to death because he had received shut-off notices. He tried to pay his bills at the bank, and he was turned away, and his electricity was shut off. So what happened here, and how is it possible, this was not that long ago, this is in the last decade, a little bit over a decade, that these things are happening in our own communities? What are we missing, and how is this not being recognized in healthcare? How is not even recognized as neighbors, as community members, as family members? The second case is a patient of mine, and this is John. He's 82 years old. He became homebound during the pandemic. Why did he become homebound? Well, he fell, and because he fell, he suddenly could not leave his house. There's also some funny things about him, is that he lives in an ethnically marginalized community that is touted to be unsafe. It happens to be the same neighborhood that I live in, which I think is perfectly fine, but according to the rest of San Francisco, it's not. And he has stairs in his house, like many San Francisco homes. The funny thing about him also is that he says he has family, they're downstairs, but I'm not really allowed to talk to them when I go see him in his home, so it's really weird about what this divide is. And then the other thing about him, for any clinicians out there, or just anyone, is that he's been termed difficult and has been dismissed from many practices. Unfortunately, when I took him onto my home-based primary care practice, I didn't know this. It was buried somewhere in the medical record, and I'm like, why did I accept this person? But it turns out that it was really important that I did accept him without seeing that and without having the boundaries and biases of why he wasn't being seen in our traditional healthcare model. So we went to him. And he told us very directly, I know that I'm isolated, and I know what I need to get out of it. I need a way to get out of my house. And that's really what was going on with him. And this is in the middle of a pandemic. So if you think about these two people, if you were their healthcare provider, if you were their health plan leader, if you were their neighbor, how do you think about their health risks? So with Marvin, we might start with cognitive ability. What was going on? I know we had a neurologist here earlier, and we know that Parkinson's undiagnosed. We know that the same is true of cognitive impairment. It is being missed routinely in primary care, and only when someone is found dead or only when someone is so incapacitated are we realizing this. So what are we missing? You look at John, who has COVID-19, arthritis, constipation, and falls. These are the things that you might see routinely documented in their medical record, and that might be it. But what we know is that there's other things missing as well, that we aren't looking at systematically, we aren't documenting, which is a problem because we're all burnt out by the number of clicks and all kinds of stuff that we have a whole nother session about this, but they're affecting people's health, and we're not capturing it. So with Marvin, he has new mobility issues, he has tech access issues, he only has a landline and a simple cell phone, I think, if I remember correctly, and is like, do not bother me with technology, like I want nothing to do with it. Self-disclosure, I left my cell phone in the taxi on the way here, which is like amazing and horrifying at the same time. I'm like very lucky I remember my husband's phone number so I can call from another phone number. I feel pretty isolated right now. And he's socially isolated. With John, he's got COVID-19. It's the middle of a pandemic. He's got what I told you, constipation. But the other things is social isolation. Nowhere in his record was that there. Did anyone notice that before we went out to his home? Probably lonely, but we don't really know because no one's ever asked. There's this idea of an unsafe neighborhood, and what does that actually mean, and does that instill increased risks or not? And mobility and tech access. These are all the things that we know are likely affecting their health, but we're not talking about it, and we're not documenting it. So this is a common slide, and similar to what was talked about earlier, is that especially in the US, we spend about 80% of our healthcare dollars on medical care. We spend the majority of money on medical care, but the bulk of what actually impacts health is 80%, which is all the other social drivers of health. And so what's missing here also in our traditional medical models that we're not actually capturing what actually impacts health, but what matters to people. Why is it important when I go see people in their home? It's not that I'm checking their stupid blood pressure, it's that they see me and I'm a friendly face, right? It's that they're, hey, Dr. Carla, my Latin patients call me Carlita. It's like really cute that I'm like this little tiny person to them and endearing person. That is what matters, is that I care enough to go to them and I think has been said, change the healthcare model to meet people where they are. The other thing to think about is, again, from a geriatrician lens, is why are these things important? So for a geriatrician, when I see my patients, the center is they value their independence and their cognitive abilities. And that's kind of at the center of their world. Can they live independently? Can they age independently at home? So what are all the factors that affect this? So we think about the physiological and biological sphere, we think about what's happening in the familial and social domain, the financial, environmental, and cognitive emotional. So these are all the factors that affect us. In a younger person, they affect us, but what happens as we get older is the following, is that these circles intersect so much more to affect someone's independence that if you are missing and not addressing one of these sectors, you're failing. And you're missing an opportunity to be preventive and to really preserve someone's independence and well-being. And so this is why, as we talk about social drivers of health, as we talk about loneliness and isolation, we have to incorporate into our traditional medical models, because otherwise we're missing an opportunity to really intervene on people. So this is my perspective from a clinical lens, but there's certainly this idea that what do we do at the population health level? I talked about individual patients, but what else can we do more broadly?
Yeah.
So Ellen.
Yeah. Before that, I want to say, what do you see the role of companion care?
Yeah, so it's really interesting. So it's not just companion care, but it's really thinking about what is driving someone's loneliness, what is driving their isolation. And for many people, it probably is having someone there that they don't have. And so with these folks that we have, we know nothing about Marvin. We know nothing. Yeah. We know that he probably had cognitive impairment. And stories like that make me think, if he had a companion, yeah, if he had a peer, would there have been someone who said, hey, Marvin, you can't pay your bills at the bank?
Yeah. Yeah.
You know?
Exactly.
If you have John, who's difficult, maybe he finds a peer and a companion that actually knows how to deal with his difficultness. Yeah. And can actually help him sort through so he doesn't get kicked out of practices, and can help him feel more connected during these periods while he's in recovery and able to get out of his house.
Yeah, it's like what we saw with Frank today.
Yeah.
So now I'm going to take it the next step out, and I'm going to talk about companion care, loneliness from a population health perspective. And what I'm going to share is 2 studies. And I'm sharing these studies because a lot of the discussion today was, how do you show outcomes? You know, what are the outcomes that health plans care about? And so the great thing about PAPA is PAPA actually invests a lot in research. That's why it's so exciting for me to be at PAPA. We really want to understand companion care, because when you think about it and you think about the model of PAPA, there is nothing out there like it. And so we have to understand, how does companion care actually impact health and health outcomes? So the 2 studies I have showing, one is with SummaCare, and that's a Medicare Advantage study, and the other one is with a Medicaid plan with Meridian. And so with the SummaCare study, that actually was done by a national actuary firm. We did not do that. And what they did is they matched members who used PAPA to members who did not use PAPA, and they matched on age and sex and risk and comorbidities. And then they followed them forward through 2021. And so what I'm going to do is highlight some of these results and kind of give you some meaning behind them. So what they found was that PAPA prevents people from becoming high ED utilizers. And I say the word prevent because, so a high ED utilizer is someone who uses the emergency department 4 or more times in a year. And so what's really, interesting about this is that you have PAPA, and it's almost, and we saw it in the data, like you kind of stop at a cliff. At 3 visits, the people who are using PAPA, they didn't keep continuing on. And then you looked at the other members, and they kept going. They had 4 or 5 or 6 visits. And so when you think like high ED utilizers for a health plan, that is a target cohort. That's about 3-4% of your population. That is an avoidable cost. And what's interesting with the SummaCare is like this wasn't necessarily a high-risk group that we were analyzing, but you still saw sort of this progression of a certain cohort that's going to start becoming high ED utilizers. And the reasons that that happens is there's probably 2 reasons. One is your condition isn't being medically managed well, right? And what are the reasons behind that? It's probably social. And then the second is just you're socially isolated. There is a pattern of health-seeking behavior for people who are totally alone. People who are socially isolated are 6 times more likely to go to the emergency department. So then you go to the Meridian study. So that study was actually done with people who are high ED utilizers. That was the target cohort. So 5 or more, emergency departments in 1 year. And in this group, this is a Medicaid group, so there's no disincentive to go to the emergency department. So in a sense, you have a health-seeking pattern that is ongoing. And when they received PAPA, we saw a 25% reduction in emergency department visits. And then in both studies, we saw equally a 14% reduction in hospital readmissions. Amazing. which, you know, is not surprising. I mean, even Frank mentioned he was in the hospital and he needed a ride home. Well, what happens when you get home? 38% of people, when surveyed, when they're discharged from the hospital, say they need social care. They're worried about their social care. They're not worried about whether they got the orders for the prescription. They're worried about who's going to pick them up. So, you know, this just really shows that, you know, there is this organic, this is the thing that actually was really interesting, that actually surprised the actuaries, and you never surprise actuaries. They were looking at the data, and they were following people, when people enrolled in PAPA, and then they were watching when did people have an inpatient admission. And they saw two spikes. The first they saw 2 months prior to the admission. And then the second spike was at month 0. And that is when actually you are admitted to the hospital. And their theory was that people knew who have a planned admission, they know they need social care, so they're signing up for PAPA. And then for people who didn't plan it and, you know, end up in the hospital, they are now seeking the social care for PAPA. So,
I mean, it's, again, I think what's really neat about us talking together, in addition to the fact that I like you, is that I see this in my practice. You know, I've been in the hospital attending when I have someone come in because they could not get a ride to dialysis. Like, that should not be happening. We are having patients tell us directly, I need help. I don't have someone to pick up my medications. And I think, just as has been said before, because I'm a home-based primary care provider and home-based palliative care and hospice, in the home, you actually see what is going on. You see the stairs. You see the lack of bus access in the neighborhood. You see the disastrous medication arrays that you're like, oh my God, I just admitted a gentleman who had been in the hospital every 2 weeks for several months for heart failure. What kept happening in the hospital? Adding more medications, adding more medications. What was happening? He was getting dizzy from all the stupid medications. What did I do? I went in, I'm like, what's going on? He's like, I don't like all these medications. I'm like, great. Let's stop some of them. What happens? We have a nurse go in every week because we don't have PAPA. Unfortunately, we don't have companion care, so I was the companion. And we see that he begins to trust us, which is a huge part, which I think is probably why you see admissions early and then they label out, because they're like, hey, I can rely on these people. Right. I don't have to run to the emergency room. I can call Dr. Carla. I can call my pal. I can call whoever it is, and they're going to be able to help me get through this, right? Yeah. And so he stabilized. I stopped like half his medications. I listened to him. I also treated his pain, which was not being done in primary care, and he's been out of the hospital for 9 months. Yeah. 9 months. Yeah, yeah. I don't even get a pat on the back for that. I give myself one, but.
Yeah, I like to think that the thing that I love about PAPA and companion care is it is personalized care. We say that at PAPA all the time. This is personalized care. The member, the PAPA can decide what they want to use it for. And you've heard that. You heard that with Frank. We have a story. This is Ronald. So Ronald is an artist, and he's a Vietnam veteran. He found out about PAPA, and he knew he was going through a really difficult medical time. And so he decided to use PAPA as a benefit. He wanted to talk to different PAPA pals virtually every week as a way, because he knew that through this medical, situation, he wanted to stay still socially connected. Mm-hmm. And so he shared his art, he shared his experience in the war, and for him it was like his therapy. Yeah. And then when, he kind of went through his recovery, then he said, oh, I don't need PAPA anymore, until I need PAPA again. And that's the thing that's, there's this real organic use of companion care. Mm-hmm. So now I'm going to take a little bit of detour and, answer a question. So I get a question, when I present the results, I get a question a lot that says, well, why? Why does companion care, actually increase office visits? Or why did it reduce emergency department visits? And so my answer is, well, as you can see, it's actually really complicated. And there's so many factors involved, right, on why someone has healthcare use behavior. And so going back, I kind of organize things, and I start to put things in a framework. And I do that probably because I'm a little bit of an academic nerd, but also it's like just helpful to kind of frame it and to think about it, like what is going on here? So I continue to fall back to my grad school days. So this is the Ronald Anderson's Access to Healthcare Framework. And so, you know, when you think about it, so I'm just gonna briefly, high level go through it, I promise. You start with the person. So if you look on the screen, you see predisposing characteristics. So that's the person, that's who you are. That is your age, that's your gender, that's your upbringing. You know, what kind of cultural beliefs were you taught about healthcare? What's your economic structure and your social structure? They're harder to change, right? And then you have what I call like more proximal factors to your healthcare behavior, like your enabling factors. What are the, you know, what's your perceived need for healthcare? Like, do you believe in prevention care? What has your doctor told you about your health status? What is your health status? What did he say and recommend? And what's their perception of actually believing in social care or social connection, which I think you've seen, you know, some believe it and some don't. And then there's the logistic aspects, which is what exactly, like, you know, do you have transportation available? Do you have a reliable social structure? Do you have good quality health care and health insurance? And then all that kind of feeds into whether you're, you know, increasing your office visits, you're going to the emergency department. And what's really, as I've been thinking about this is a work in progress, you know, companion care actually can go in and influence all of these. And it's just so powerful when you think about it. So, and of course, all of this has to be surrounded by the idea that we are, you know, we get influenced by the external factors. You know, what is going on in policy that's going to help move the needle? What are the current trends going on? You know, the rise in telemedicine, and what are the historical trends? What are the things that has driven the health inequities that we see today?
You know, Ellen, I think this, we spent some time talking about this, and I think it's just, we keep thinking about how to predict health, how to predict risk, and we don't often think about how to protect ourselves. And I think, like with people like Frank and others who don't have a support community, it's how do you create one and help them create one so they feel a sense of belonging. This need to belong and to be a part of a tribe is very human. It is a core of humanity, and we're losing it. And that's a whole nother conversation for another day or over dinner and drinks. But this is why, you know, the work that you all are doing is really impactful, and you see it. Again, you see it. These were real stories, and I see it in my practice every day.
Yeah, and this doesn't just affect older adults.
No.
I mean, we talked a lot about older adults, but you know, we did some study, and now we're looking at the prevalence of loneliness in the Medicaid population. So you still see, you know, even in young age groups, severe lonely, which we know is such a high risk factor. I mean, 11% on average are severely lonely. I mean, you still have about 30% that are lonely. And so I think it's, you know, we often in the Medicaid space, you think of the, you know, the three primary drivers, social determinants of health, and it's food and housing and transportation. And that's absolutely true. But social isolation and loneliness is also, you know, a really big factor. And I think we don't think about it that much with the Medicaid population.
No, we don't. And I think what was also enlightening about hearing earlier is that I don't think I really understood the full spectrum of what, you know, PAPA does, because it's different from some of the peer programs that I work with around the country. There's almost a melding of all the determinants or the drivers, and that you have a companion that is also getting over the transportation barrier and the food insecurity barrier. And so that's kind of really neat. It's like 3 for 1.
Yeah, yeah, exactly.
So
yeah, and I think of like the prenatal and postpartum experience. You know, let's think of that in the Medicaid population. I mean, one, it is from a prenatal, it's one of the most intensive primary care journeys you have to go every 3 weeks. And then on the postpartum side, it actually can be one of the loneliest times, even though you're actually never alone again. And so when you think of the interventions out there, you know, there's the doula programs and community health workers and PAPA. The common thread through them all is actually companionship. You know, doulas become friends with their members. The PAPA pals, as you saw, they become They can become friends. And when you have a friend and an advocate going with you to the doctors, like that's an immunity boost, you know?
And I think as we think about this, and I've shared with you, and you've met my daughter, but I have a 2.5-year-old. So I was pregnant during the pandemic, which was not exactly the most social experience of my life. So I don't think anyone in my division saw me pregnant, and then suddenly I had this child. It was incredibly lonely and incredibly isolating, and I don't think I realized that until I was kind of coming out of it, that I was like, oh my God, what did I just go through? And I thought, and seeing you do this work just made me think about myself. I'm not a Medicaid recipient. I live comfortably, and if I was experiencing that and I still had limits to what I could get, what happens to people that don't have the resources that I have? And I am so lucky that I was able to get help for myself if I had postpartum depression, unlike some very sad cases we've had recently in the country.
Yeah.
And you think about, again, if we were reaching out more to this very potentially vulnerable group, like what are those outcomes, not only for the mother herself, but for the children? I'm really interested, I'm kind of going on a side so you can tell me to shut up, but I'm really interested in adverse childhood experiences, and I don't think we really understand enough. This is my next project I'm thinking about, and what those early life experiences do to predict later life loneliness and isolation, and is there a correlation? Can we do anything to stop the curve earlier? Ultimately, again, I think my interest as a geriatrician is that I find older adults way more interesting, but the effect on health is so much greater in a smaller, compressed amount of time. But if we have people that are younger that have a much longer period experiencing loneliness, we don't actually understand the dose of loneliness or the dose of isolation that needs to happen. We just had a real world experiment called COVID-19, which did happen, is happening, and we didn't actually collect real-time data. We have some, but we don't actually know. I know personally, I witnessed people die in nursing homes from isolation directly. And I have started putting social isolation on death certificates, and the coroner's office call me all the time, pissed off. And similarly, in that same article, I wrote about racial inequalities being causes of death, because that is also happening and we're not acknowledging it. So it's time to actually talk about what's killing people and trying to do something upstream about it.
Right, I totally agree that trauma as a child, what is that trajectory? I mean, I often look at the Medicaid data, and Kelsey and I talk about it, and we think okay, now you're in your 40s and you're severely lonely. In your 50s, now we're seeing this uptick. What's gonna happen when you're 70, when nobody is intervening? I mean, there's this idea you and I talk about, persistent loneliness. At that point, you're just trying to maintain. You may not be able to actually reduce it anymore. You're just trying to hope it doesn't get worse, One of the things we see in our data, so if the loneliness scale is essentially 3 to 9. 3, you're not lonely. 9, you are severely lonely. But when you look at the data and you kind of look at what that trend, at 9, it's a ceiling effect, which means if you could keep going, you could have people scoring 15,
Yep.
So Carla, I have 2 questions for you. The first is, as a researcher, what was your aha moment, in your experience? And then the second is, if you were the czar of health and you had an unlimited budget, what is your dream scenario in 5 years?
Yeah, so I think my aha moment, again, I had this as I started looking at this because I saw it in my practice, both in people's homes and in the hospital. I knew it affected people's health. I just did not realize the effect that it did. So the research I initially conducted, I showed that if you were lonely, regardless of your other comorbidities and the big traditional model risk factors for health, you had a 43% increased risk of death and a 59% increased risk of functional decline. And so that was my moment, which was, we're missing this and we're not asking about this. And I think we are treating the wrong things. One of my colleagues at UCSF has done amazing work on end of life and palliative care, in which I also work, and we see, and what we believe is that when we know that people that are lonely have increased risk of polypharmacy. Why? Because we're misdiagnosing them. We think it's depression, or maybe it's comorbid depression, but we're treating that, and we're not actually addressing the loneliness. I think about the conversation we had about Parkinson's patient and what happens to people as they lose their mobility and are getting more isolated at home. Is that preventable? And are they also getting more lonely and isolated and therefore having other health effects? So that was my aha moment, is that these are radically affecting health and we could be preventing it. If I were czar of the world, I think there's a couple things that I would do. And I think I come from a public health background also. And so I really think about this from a population health perspective and public health perspective, which is, you know, what is primary prevention and what is secondary prevention? So primary prevention is, can we identify people who are at risk for loneliness and isolation, which traditionally have been women, people of lower socioeconomic status, older adults, although now that's kind of changing. We're seeing it's more younger people as well. LGBTQ older adults are all people really, and people with recent losses. So can we identify these people earlier? So this is the pyramid here. So people who are at risk, so we prevent those health consequences. So we prevent them before they start overutilizing healthcare and instead fix those things. And secondary prevention, maybe someone is already starting to disconnect, but they're not completely isolated. Can we bend the curve a little bit? So I think about that in terms of the people that we just discussed. So I discussed the case of Marvin. Well, Marvin likely was at the top of the pyramid already, right? He died and no one even noticed. That is a tragedy, and yet I'm sure it happens all around us in our own communities. And so can we create a framework where we're identifying this? This is an accepted part of healthcare without additional work for all of us since we're all burnt out. Both patients and providers. There's a great article in Time this week about patients being burnt out. So can we bend the curve? And if we can't, can we help, since I work in hospice also, so people are not isolated at the end of life, so that they do have a companion at the death. There's death doulas, actually. With John, my patient during COVID, he's starting to disconnect. What can we do for him? What would it look like if his health plan did actually include social benefits? You know, he actually called his health plan asking for help. And the health plan was like, you don't have a mental health diagnosis. And I'm like, ask me, I can tell you there's a ton there. But I hadn't seen him yet, and so that's something. And then I think, as you say, like, and then earlier people, pregnant women who are at risk. I also think about my daughter who's 2.5 and born in a pandemic. I have no idea what's gonna happen. I think because I study this, I tried very hard to keep her socially connected safely during the pandemic, but that's hard. I hope she's gonna be okay, but I have no idea. So I think that's really what this is about, is that if I had my say, I would really flip how we're looking and paying for healthcare and do what more of sane countries around the world are doing, which is spending much more money and resources and time and energy on social care. I think our speaker before said it really well, you measure what you value, right? And you value what you measure. And so if we're not doing that concretely in our healthcare encounters, it tells us what it is. I will also say, my final thought, is that we are incredibly ageist, but not in the way that I am. And we do not value older adults, and we do not value aging. There's a reason why there aren't enough geriatricians in the world. It's because it's not sexy. It's not, you know, I should have job security. I should be sought after, but guess what? I'm not, because I'm a widget.
You are not a widget.
And I'll get off my soapbox.
Thank you, Carla. So I'm actually now going to open up for any questions from the audience.
Did we drop the mic? Is that what's going on? Is there nothing else to say?
So, quick question. If you look at the graph that you showed for Medicaid population, you know, where the, you know, even the younger population feels more isolated, has anybody looked at Eastern countries where the culture is such that you would have 3 generations living under the same roof? So we talk about isolation, but we don't talk about the culture significance of that. It's more cultural driven. It exists in Western countries way more than it exists in Eastern countries or Middle East, right? So that, sorry, go ahead.
No, go for it.
No, so that's one of the most important points, but we don't talk about that, right? And then the second comment I wanted to make, we talk about healthcare expenditure, you know, but I think the healthcare is just more costly here. To give you an example, I was recently in India. A month's supply of Xarelto here cost $500. $500 will get you over 2 years' supply of Xarelto in India. Same manufacturer, you know? So it's not that we're spending more, it's just cost more.
I think it's probably both, though, and if I can answer it, I'm going to answer your question in two parts. So there's actually really good international data on loneliness and isolation, and we're not alone, ironically. So the rates of loneliness and isolation around the world are similar. That being said, not every country is doing the studies to actually look at prevalence rates. I will say what's really exciting is that the World Health Organization really is taking this issue very seriously, and we're going to see some work coming out of the World Health Organization looking at cross-national collaborations around this. I think we need to understand more about social fabrics. I come from a Latin American and Italian family where our social structures and family structures are different. We don't understand enough, but there are some cultural variations there. The second part about cost, I think you're right in terms of things are more expensive, but again, I get back to we're misaligned. So I took care of a 98-year-old gentleman who went to the hospital from his assisted living because he fell. He had $1 million workup, he had an echo, he had a CAT scan, he had whatever. What happened? He actually had clogged ears from earwax, okay? I saw him at home, I cleaned his damn ears. You know, like that's actually, what did I get paid? I think maybe $50, right? What did all that cost? So we're not, and why is that happening? Is because how we look at aging, let's pay for all these things, let's do the easy test and not actually look at the person and do an exam. So I think it's both, right? And that CAT scan is $1,000 and my amazing ear lavage was fabulous and $50.
Any other questions? We have one more question.
Two questions. Sorry, I'm cheating.
I charge for the second one. I pay my salary as a geriatrician.
As long as it comes with an ear lavage.
I do toenail care for free too, if you're interested.
Elementary question. Is loneliness and isolation the same thing?
Great question.
Socially
I meant to go through these introductions, through these explanations. No, they're not, and I think that's a really important question because we conflate them in the literature, and if you actually look at the literature, we've done a terrible job at explaining, and I think it gets back to measurement because some of the things that we say are measuring isolation actually ask about loneliness. I think the most simple way to look at it is loneliness is really the subjective feeling of being isolated, right? So I can't tell you that you're lonely, it's really about your experience. I can ask you some structured questions that will get at that, and isolation really is more about a quantifiable number of relationships. So they can coexist, but they're not the same. And I think the reason why that's important is that in our interventions probably work differently. And I think one of the things we need to look at from a population health perspective is as we look at solutions, companion care and other things, is what are we trying to solve? Sometimes one solution, potentially companion care as an example, can do both, but not necessarily. So as we think about more people entering the space and wanting to create interventions, is that are we matching the intervention to the problem?
Super helpful, thank you. The second question, it may relate to your first answer. What companion care needs to be in person or done by a person? And what other alternatives are there?
Yeah, that's a really great question, and I don't think we know completely yet. There was a really interesting study by Louise Hockley, who's a fabulous researcher out of Newark in Chicago, who actually compared people that had, visits with family in person versus telephonically and versus video. And while the visit and telephone things did some things to reduce, it was not the same as in person. So since I lost my cell phone, I am a technology skeptic. I'm also in the age generation that I'm 44, so I'm somewhere in the middle where I'm like super analog and love it until I lose my Post-its. But I think that we are overly driving some of the virtual and I think forgetting how important human touch and connection is. And I think we're seeing the same thing in telemedicine, that it is an incredible thing for access, is to be able to see a neurologist virtually when you otherwise have nothing, and to decrease the 30-minute, walking to the parking lot, which used to drive me nuts when I was seeing patients in clinic. I'm like, you want me to see my 98 person in 15 minutes? It's going to take them 30 minutes to walk into my room. I'm already 45 minutes behind now. So I think it's understanding what you're trying to solve, right? So in some rural communities or in some areas where you cannot get there in person, that probably is something that can help. But we can't assume it's going to solve everything. And in general, I don't think we can assume that one thing is going to solve everything. I probably, to make Andrew happy, I should say Papa's going to solve everything. But as an independent academic researcher, I'd like to say that you have to think about what are you trying to solve, and there are different problems that people have. I've told this story before, but when I lost my father 4 years ago and my mom became a widow, what she needed was grief counseling and therapy to deal with her loneliness, right? Now it's a different story, but the usual answer will be go to a senior center. My mom didn't need a senior center. She needed to cope with the loss of her partner of 50 years. And so it's matching again and understanding what you're dealing with. And yes, some things can be done virtually.
All right. Well, thank you, Carla, so much.
you.
So appreciate it.